O Max eu conheci o ano passado em Lisboa, no Congresso de Portugal, e ele é um eletrofisiologista russo que devido à guerra, veio para a Alemanha e focou muito em aulas de anatomia e realmente as aulas dele são especiais, muito boas, então a gente conseguiu viabilizar hoje para ele estar aqui e eu acho que vai ser muito interessante essa sessão. E esperamos que tenha um próximo. We hope we can have other sessions in the future, Max. Would be great. Rodrigo, pode abrir.
É, ok, pessoal, sejam bem-vindos aí para mais uma reunião nossa da Eletrofisiologia, todas as quartas, como vocês estão sabendo. E hoje, em especial, a gente tem um convidado, Dr. Maxim Didenko, que ele é eletrofisiologista, hoje trabalha na Alemanha e tem uma experiência grande, tem um paper interessante sobre anatomia e eletrofisiologia e vai dar essa aula para a gente. Professor Didenko, it's a pleasure for us to have you here in our weekly meeting at INCOR, and please, the time is all yours. And if you want to introduce yourself, please, dear guests. And of course, everybody, if anyone have any question, please just go ahead. This is a really informal meeting, so no worries. We're here just to learn a little more with Professor Didenko.
Okay, so good morning. Yeah, you have an early morning now, and my name is Maxim Didenko. So I'm originally from Russia. Now already 2 years. I'm based in Badenhausen, Germany. With the Professor Sommer, and I am an electrophysiologist. So in St. Petersburg, I was in university hospital head of EP department about 20 years, and anatomy, it's just let's say my hobby and passion. And actually, because when I started to interesting in this area, in this field and research, then I have to say my life in EP lab become much easier. So that's I always try to say for everybody. And so when you really know all details, then your electrophysiological knowledge will be better. So you will understand much better, and of course, your life will be easier. Yeah. So in general, for cardiologists, it's extremely important to know anatomy. But I think for us, for electrophysiologists, especially because the signals, so electrical signals produced by anatomical structures. And when we know what is somewhere here in this heart shadow, which we usually use in EP lab, so we have to understand wherever we place our catheters, which structures are, why we have these kind of signals, fractionated, non-fractionated, double spikes, etc. And then we really have to correlate all our signals with the specific structures in order to understand the mechanism of arrhythmia, so from which area, in order to understand where we have to ablate it, and of course, how we have to ablate it in a safe manner. And even when we use all these nice maps, it's even we lose some information, like for example fiber orientation, or like in this case, this is we usually can see the nice ventricle maps, but look how it looks like inside the heart. We don't see, unfortunately, usually these trabeculations. And of course, we have to keep in mind, because then we have to be in a safe side. And of course, we cannot manipulate with our catheter so easy with this kind of trabeculations. I also would like to say a couple of words about embryology of the heart. This is really big area. I don't want to stress out just a couple of points. And these points are that we know that all idiopathic arrhythmias are coming not from all tissue, ventricle or atrium tissue. So, for example, in the atriums, we know this is crista terminalis in the right atrium. Most often we have atrial tachycardias from this area. And this is connection of two different embryological tissue. In the left atrium, the same, posterior wall and the pulmonary veins. This is also connections of two different embryological tissue, primitive left atrium and splanchnic plexus. So this is posterior wall of venous part, sinus venarum, and where the crista terminalis is a connection with the primitive right atrium. The same for splanchnic plexus. Splanchnic plexus form lungs and the pulmonary veins. That's why anatomy of the pulmonary veins is really depend from the lungs anatomy. We have, for example, superior veins, they are anteriorly directed because the anterior superior lobes of the lung, and then inferior veins, they are posteriorly directed because the lungs is inferior posterior located, the lobes. And then, of course, we have more often 3 veins on the right side because on the right side we have 3 lobes. Another point, this is position of the heart in the thorax. And now I will switch to another camera in order to show some specimens. So, unfortunately, all anatomical nomenclature was made from so-called Valentine position. So we have a left heart, right heart. We have anterior structures like, for example, leaflets or anterior fascicles, papillary muscles, a lot of structures called anterior. But in the real life, like you can see on the right side and in my hands, in the real life, so we have a right ventricle, which is mostly anterior ventricle, left ventricle, which is mostly posterior, right atrium anterior, and the left atrium posterior. If you can see on this perpendicular cut through the whole body, this is a sternum here, and what we can see, this is a level on the right ventricular outflow tract, aorta, and we can see this is the right atrium anterior and the left atrium most posterior structure in the thorax. And then the same for the ventricle side. This is the right ventricle here and the left ventricle, which are anterior and posterior. Why it's so important? Because if we understand how it looks like in relationship to, for example, precordial leads, we can immediately understand the vector analysis and from which area it comes. The same for example, for Eindhoven triangle, so our leads on 1, 2, 3 in AVR and AVF. So what we can see, if something originated in the superior area will create the inferior axis and the positive deflection in leads 2, 3 AVF. And of course, during procedure, we also have to keep in mind, because then we will manipulate with our catheters much more accurate. So, and this is actually mentioned in this publication. I really recommend to review this. It was published in December last year, how to best describe locations and what they say. So this is how we can see all this, for example, accessory pathway classification. This is the old classification where we have so-called anterior, lateral. So this is the specimen on the atriums. I didn't explain. So this is a plastinated human heart specimen. So this is a real specimen from the human, but plastinated, so filled with the silicone. And then posterior, for example, accessory pathway, lateral, etc., and septal. But in the real life, and they stated that this is obviously wrong because it's clear that the diaphragmatic surface, which is here, of the heart is positioned inferiorly rather than posteriorly. So, and this is what they propose. Actually, already not the first time. I think Cristiano, I remember that in 1999, because you was already published in publication where they propose to use this correct orientation of the accessory pathway, where here is the superior, this is inferior, this is anterior where the tricuspid valve, and posterior where the mitral valve, and of course superior paraseptal, inferior paraseptal. So this is what they encourage, and they really, for the new publication, ask to use this nomenclature. As I already said, this is also important for our ECG diagnosis. So why it's also anatomy important? Probably it's pretty simple stuff, but what we can see here, this is just normal precordial leads, and we know that it has mostly negative QRS complex in lead B1. So it means if we take a look on again on this card, it means for us that activation goes out of lead 1. But in the same time, we know that R wave we have here. And I don't know if we can make a little bit interactive. Maybe somebody can unmute and say why we have a small R wave in lead B1. So just to logical, it means that some structures activated towards to V1. So main vector is out of lead V1, but something activated towards to lead V1. What any ideas?
Let's try the fellows, Dr. Didenko. Let's see how is their English. I'm seeing actually that some fellows are getting out of the room.
Yeah, it's pretty simple, actually.
Yeah, sure. Just kidding.
But maybe somebody can.
Let's check. Maybe
you tell somebody.
Victor, what do you think, Victor? Come, are you here?
Yes. Well, we see a little R wave in V1 because it's probably the septal activation of the.
Absolutely right. So the septum activated towards to lead V1. So in this direction, yeah. But can you maybe answer for the next question? Why it's activated not synchronously, so not both sides, right and left, or from right to left? Why it's activated from left side and actually from posterior side to the anterior side?
That is a little harder. I don't know also.
Okay.
What do you think, Victor?
Yes. Well, I would expect it to be synchronous because it goes through the his bundle, but maybe you can teach us.
Yeah. So, but we know it's not synchronous, because otherwise we would not have R wave in lead V1, correct? So actually it's because of two, again, anatomical reasons. So first of all, connections of the left bundle with the Purkinje fibers is becoming earlier. That's, for example, on the right side, first connection with the Purkinje fibers a little bit later. It's in the area where the border between the moderator band and trabecular septum marginalis. So it means when the activation reach the Purkinje fibers, of course, it will goes faster in this area, and then activation goes in this direction. So that's why when we don't see the R wave, it means we have some problems with activation of the septum, and it's very bad sign. The second point, the left Purkinje fibers, they are faster than on the right side. So on the left side, they have more connexin 43, so which is fastest connexin in the area. So I just gave you just one example how we can correlate all our not only P but ACG phenomenon with anatomy, how are they all explained by anatomy. Actually, that's why we also can see sometimes the R wave in V6, because it's also activation septum from this lead. So when we're talking about position, of course, we have not, we need to thank you for your answer, and thank you for participation, for active participation. Thank you so much. So we can see that the heart can be horizontally oriented or more of a vertical in young patients or in old patients, and for example, thick patients or patient with a heart failure. So it also will create a different phenomenon. Of course, we have X-ray and an AP view with all the signs. We can see the tricuspid valve lower than the mitral valve, then directly connected aortic valve. Of course, we will not stop on this. You probably know it very well, just a little bit. And here we have our main projections. Of course, in an era with the 3D mapping, we can use any projections, but still these LEO, REO remain the main projections and main views. And in LEO projection, we can better understand anatomy and orientation compared to lateral wall and the septum, and in area projection compared to apex, posterior wall, and coronary sinus. So let's see how we can proceed. Let's switch to the arrhythmias. And as you can see, it's somehow anatomy, but I will talk from the electrophysiologist point of view, so from the tachyarrhythmias point of view. And what we can see here, this is a Koch triangle area, and we can correlate it with a real specimen here. This is our aerial projection, and this is superior vena cava, inferior vena cava, fossa ovalis, coronary sinus here, the septal leaflet, right ventricle. And in order to better understand this anatomy, I can transilluminate this structure here, which is membranous septum, where the His bundle is located. And just below the His bundle, the compact part of AV node is located. Here, along the tendon of Todaro, closely to the anterior limb of the fossa ovalis, the area with the fast pathways, here the area with the slow pathways, so-called pathways. So there is no any specific conduction pathways in atriums, but this area are slowly conducted, and they have a longer refractory period, and this is a faster conducted structures, and with this longer refractory period, this is shorter refractory period.
Max?
So, yeah.
Yeah, Cristiano. There's some difference in orientation of the fibers here on the AV node, or just the muscle is no, there's no difference. Muscular fibers.
Yeah, so a very good question. First of all, there is no border between these kind of cells. But if the difference, the physiological difference, is big enough to make it possible for reentry, then patient can have a reentry. This is the first point. The second point, so they have a different properties on the cells, and again with the different connexins on the membranous cells, and then it's provide this kind of properties. And as we know, one of the main properties is decremental conduction in this area here. Unfortunately, that especially in a young population with inherent diseases, these areas can be switched. So sometimes, and I had one case like this, It was difficult because it was also my friend. The fast pathways are located where the slow pathways should be. So it's possible. And the second point that we have to keep in mind, I will show you maybe just directly on this slide here. So usually we understand the arrhythmia like this, yeah, in the so-called 2D, let's say, two-dimensional picture, yeah. So the reentry is slow pathway coming here antegrade and retrograde here, but in real life, the story more complex, and actually I will show with this specimen here, or even better here. So this is right atrium, left atrium, aorta here. This is the coronary sinus, and this is a slow pathway area I will show from this side. So this is a membranous septum where the His is located. Here is AV node, slow pathway again. And if I turn on this side here, so this is our typical place where we ablate the slow pathways, yeah, here. This is a His catheter, this is slow pathway. So this is, let's say, an atrial view. But we can see that all this tissue here actually also involved, and it was nicely described in Nakagawa-Jackman publication. This I can really recommend. So what you can see, all this activation goes on the left side as well. And okay, so usually where mostly in most cases can be successful ablate in this area here, but sometimes if it's located more to the left, and you can see slow pathway ablation region can be inside the coronary sinus. And you can see anatomically it can be easily explained. So this area here, this tissue here can be also involved in the reentry and activation. And then this area here, we can ablate through the coronary sinus here, or through the transeptal puncture here. I don't know if I capture your question and answered.
Yeah, if there's some anatomical view for the fiber orientation, but is all a region, not a specific area. It's very complex. This area is the trigonus is very complex area.
Yeah. So as we can see, this is area LO projection, and we can see all this tissue here, which is anatomically here, are involved in this tachycardia.
Great.
So this is just a simple imagination how we can imagine and transfer it to our X-ray. Again, this is our ablation catheter. So I just show on the real specimen as well. And we go through our His catheter is placed here. And again, I will show you with the transillumination. So we are place it here. You can nicely see that if sometimes you cannot see the His, you usually have to be a little bit so deceptively, but can be a little bit lower, you know, because the His bundle is usually on the lower border between membranous septum and the ventricle septum. But in the same time, the direction of the His bundle like this, so it goes anteriorly and superiorly. It's interesting then that right bundle and the left bundle, they then directed anteriorly but inferiorly. So it means it's like this angulation in His bundle compared to left and right bundles. So this is also interesting. And then when we ablate, we have to place our catheter here in between the coronary sinus and the tricuspid valve. And in most cases, 70, 75 80%, we can ablate the slow pathway in this area here. What is important, of course, you have to make the septal pressure in order to be more septally, but if you make it too much, you will go to the coronary sinus. Sometimes, as we already discussed, we have to go towards to the coronary sinus ostium here, area, or even here in the mouth, so inside the coronary sinus, but in typical cases, it can be done here. You probably know that in pediatric practice, it's also described in several publications that it can be done like the line in this area between the tricuspid valve and coronary sinus. Of course, we can go higher, but then we will increase the risk of the AV block and damaging a fast pathway or AV node. That's why we are trying to avoid to be close to this area here. But you can nicely see that this area not so big in between the his catheter, for example, and this area here. What the specific signs of this area? We know that it's tissue between the coronary sinus with the AV ratio 1:3 or 1:7. And this is something very interesting. Somebody has any ideas why in this area specifically? So when we place our ablation catheter here, which is atrium, it has a big ventricle spike and small atrium spike. Somebody have any ideas, explanations? Maybe again you can ask somebody.
Let's go. The fellows are being tested today. Nice, Max.
It's not a test. It's just to try to a little bit involved in the.
Sure, you're right. Let's go. Maybe Victor Hugo is here. Victor Hugo.
Hello.
Yeah.
Victor Hugo, did you understand the question?
Yeah, why the ventricular signal is bigger?
Yeah, much bigger than atrium.
I think it's a real septal atrioventricular, maybe. Oh,
Atrioventricular septum.
yeah.
Perfect. This is absolutely great and correct answer. And what is here? So this is the atrium tissue, yeah?
Yeah.
And what the tissue is just below this atrium?
It's posterior inferior recess of ventricular left
Perfect.
ventricle.
Perfect. Absolutely right. Because this is specific only here. For example, if we are going to the area where the atrial flutter ablation is, so then we usually already here, just close to tricuspid valve and the atrium, we will have a small ventricle spike and atrium spike. And if we take a look on this specimen here, I will show you. So this is our area projection, superior vena cava, inferior vena cava. This is fossa ovalis here, the coronary sinus, tricuspid valve. And again, this is our area where we ablate the slow pathways. And then I open this area here. And what we can see, again, I placed our catheter here. We can see that the atrium tissue just above the ventricle tissue, ventricle septum here in this area. So, and you're right, because the mitral valve and the tricuspid valve, they have a different level of connection. So this is a mitral valve, atrium, left atrium ending here, and then the left ventricle starting, so left ventricle septum, and then tricuspid valve here. So in between these, so we have atrium tissue, white here, and dark, it's here. So, and you're right, this area here, we call posterior superior process of the left ventricle. And it's explain electrophysiological phenomena, and also explain how we can ablate the ventricular arrhythmias from this area. I can show you in another way. So this is our LEO projection. And what we can see here, this is our slow pathway ablation. This is left ventricle here, and this is posterior superior process of the left ventricle. So great knowledge. It's again just with the zoom, atrial tissue, ventricle tissue, like a sandwich. So this is one of our case. So you can see where we had to ablate really on the left side, the slow pathways. And ablation was successful. So maybe so atrial flutter or axis pathway, what is more interesting? Because
I think, go ahead.
Go, Rodrigo.
I,
I
I think gastric pathway people are going to
Yeah.
like more.
I would say the same.
Yeah, so the pathways, just a little bit. What we know, this is always embryological problem. So in development stage, the actually atriums and the ventricles, they are connected to each other, and then the specific process create the AV rings and divide atrium and the ventricles. And if it's process disturbed, then we have axis pathway, which can connect actually different types of tissue, conduction tissue, atrium and the ventricles, and they in most cases so-called atrioventricular connections, and sometimes they can be so-called to different physiology. So we call Kent physiology, but Kent, because the Kent actually described the Mahaim, so he described actually atriofascicular pathway. But we call them Kent physiology and think that we know that they are from rocking myocardium and they don't have decremental properties. And in the same time, Mahaim physiology, axis pathway, they from conduction systems or from the same system which create AV node and the pathway, slow and fast pathway, and they have a decremental properties. You can see that Mahaim usually you can find only on the right side. Working myocardium axis pathway can be almost everywhere, exclude this area here, which is, this is atrium U, this is LOU. You can see here, this is an anterior or superior leaflet of the mitral valve, also called anterior mitral continuity. It's a really fibrotic tissue, and here usually we cannot see any axis pathways. Just a couple of words about ACG. We already know the normal ACG. And again, if the patient has a left-sided, so, and then imagine that it's posterior, then we will have a positive delta wave in lead V1 and negative in V6. And the right-sided, if it's actually anterior axis pathway, then it goes in other way, and then it's negative in lead V1 and positive in lead V6. Just to give you some imagination how we can look at the same. We can imagine for our Cohen triangle. So you can see here, if it's so-called anterior or superior axis pathway, then the delta wave will be positive in 2 and 3 AVF. If it's inferior or posterior axis pathway, then it will be superior axis of delta wave, and then it will have a negative in delta wave in lead 2 and 3 AVF. So this is just give you how it happens. This is a nice multi polar, pretty dense mapping of the accessories pathway with the retrograde activation. And what we can see here during the activation, we can actually even see the activation in this electrogram of the accessories pathway, which is here, located here. So, and then it's going to atrium, and then we have atrial activation. So ventricle, accessories pathway activation, and then atrium activation. This is nice how we can nicely see it now. For the left-sided, we can ablate it from the transeptal puncture or transaortic as well. Nowadays, almost always for transeptal puncture. For some specific areas, like a superior paraseptal accessories pathways, which are located in this area here, very close to his bundle, and we have this case with the monip with it. So this is a positive deflection, so it's a superior allocation and usually isoelectric because it's septum. And then in LITV1, then we can see that its earliest activation really close to his. And then we have to keep in mind that some structures are located very close to this area. And in this case, this is a so-called non-coronary cusp, and then this non-coronary cusp is located very close to this area here, and we can ablate it from non-coronary cusp or from this part of right coronary cusp, then it will be more ventricle side. So you can see here our catheter is located here. I will show you on this specimen here, and how the ablation catheter looks like. So you can see here, this is our membranous septum where the his is located. This is the ventricle, and this is non-coronary cusp and the right coronary cusp here. And then if you go in this direction here, you will be on the right spot, but pretty safe from the his bundle, especially when we know that the his bundle is actually located on the lower side, on the inferior side of the membranous septum. So it's here, and this, of course, it will be somehow defend from our energy by this fibrotic tissue. Of course, you can go deeper, and then you anyway have a chance to damage the his, but at least it can be safer from this area here. This is area which is pretty difficult sometimes to ablate, so-called posteroseptal or inferoseptal area, where we can see this is endocardial pathways or epicardial pathways, and pretty often they can be epicardial located, and then you can see how it looks like. Let's see in a real specimen this area. This is a right atrium, left atrium. What is specific characteristic of this anatomical areas here? This is the coronary sinus here. The coronary sinus in the EP lab, we call all this structure coronary sinus, but anatomically, this is already the great cardiac vein. And the coronary sinus is ending here. Actually, this is the area where the Wiesen valve is located, and usually this vein here comes. This is the vein of Marshall. And you can nicely see that the coronary sinus covered by muscles, and you can easily imagine that sometimes these fibers can be connected to the ventricle, especially if it's the patient can have some diverticulums, etc., and that also create some additional conditions for these accessories pathways.
Max,
And yeah.
just a quick question. We sometimes we try to, and we did a publication many years ago about the epicardial access to go to this to SR pathways, and what we found that in this region, going to AP to substitute almost make no sense, and we think that is because fat. How thick is fat in this area? and there's some area on the annulus that there's less fat that the epicardial, the subxiphoid epicardial can be an option.
Yeah, you're absolutely right. So if we can see here, this is a corner sinus, and this is all this fat. And if we go deeper, so we also call this area here so-called posterior pyramidalis space, which is, you're right, full of fat. We also sometimes call it the cardiac crux area. But the corny sinus itself, not always covered by fat, sometimes yes, in this case, for example. But yeah, you're right.
And the relationship to the arteries, but when we burn inside coronary sinus, we get worried about the artery, and
Yeah, this is a
that would be
very,
also interesting.
very good question, because the problem is that it's really variable situation. So this relationship, for example, in this case, you can see the coronary sinus here, and then this is the here the last part of right coronary artery. This is the right coronary artery here, and this is the ventricle posterior inferior interventricle artery here, and then the circumflex artery in this case almost ending here, some maybe branch here, but sometimes you can see this is really above the coronary sinus. And unfortunately, you're right that it's chance that we can damage the coronary artery. Maybe what, at least in our specimen, mostly, if you really ablate in the coronary sinus, so we have to keep in mind that we have to go, so our contact force should be directed towards to the myocardium. And of course, better to make a coronary angio in order to be on the safe side, which I almost always do if I go deeper than the coronary sinus ostium.
Great, thanks.
So we have a couple of minutes, and we have a special request for the ablation from the right ventricle outflow tract. So we already discussed this area here, but that was one of the possible complication in the ablation in this area. This is tamponade and the perforation. So why it can happen? As you can see here, this area here, they're pretty smooth, but the really anterior part here, it's really trabeculated part. So what it means that if you go with your catheter really deep, you have a very big chance to have a pop and perforation. So usually, maybe not on this heart, so maybe here. Usually this area here, so anterior wall, not covered by fat, but here and to aorta and the interventricular septum, we have a fat. But this area here, which is anterior or anterior lateral wall, the thickness of the myocardium in this area, unfortunately, can be pretty not so thick. Another point which we have to keep in mind in this area, this is a close relationship with the coronary arteries. So if you take a look on this specimen here, so this is, again, we can see how thin the myocardium here compared to, for example, to the lateral wall here. And then you can see the LAD, and we published a couple of cases where we it was collection, so it was not our cases, but Dilling Boer from Belgium, she published a case series, and I was co-author of this publication where there was registered LAD occlusion during this ablation. So this is what we always have to keep in mind, that the right ventricular outflow tract, this is nowadays class 1 indication for ablation, but at the same time, of course, it's not so life-threatening arrhythmia, and then we have to be really on the safe side. So before we have questions, I will make a kind of small conclusions, and then I would like to say by word of Mark Jodison, who said in 2007, back to basic, learn electrophysiology. He is our pioneer of electrophysiology. He unfortunately passed away. But I would say that it would be great if we would do it through the fundamental correlation with anatomy. And this is some additional information I probably can send you also, or I've heard you record, yeah, this session. Maybe you can see it then later. This is some materials on our website and also on YouTube that you can free to use. And of course, if you have any questions, I still have all my specimens here. Please feel free, and thank you so much for your attention.
Thank you so much. It's a great presentation, and I think this open space for a second one now, the atria and ventricle, because it's so. Oh, Francisco is here. Francisco was the guy who introduced me to Max,
Francisco, hi, how are you?
and always great presentation. Was a pleasure to have you with us, and I think we need to prepare another session for the other, because this is so great, and the different view what we are used to see. And as I'll tell the fellows, especially when we have starting fellows, what is most important? I need to read the book or no? The first most important thing is to understand anatomy, because it's essential for us.
Yeah, definitely.
Thank you, Professor Didenko. It's a very, very good lecture. I think was the best lecture I saw in anatomy, because you managed to use both the specimens and also the slides. So it was really nice. Thank you very much. I think, as Cristiano said, we're dealing with an audience with a lot of fellows, and the fellowship is also very hard to do and to pursue. You want to pursue a career in electrophysiology. You really want to study about anatomy, and anatomy is everything, I would say. So what you understand what you do in electrophysiology when you understand really deeply what anatomy is. So thank you very much, and I hope everybody enjoyed it. If anyone has any questions specifically regarding some of the discussions of this lecture, please just open your microphones and go ahead. And thank you again. I think we're in the top of the time, but I think we can have room for 1 or 2 questions.
Yeah.
I can see Francisco, Pedro Carmo, some words from Portugal. Pedro, tudo bem?
Nice to see
Como
you.
está, Pedro? Tudo bem?
Hello.
Oh, Daniel também. Os amigos de Portugal aí.
Max is fantastic. It's always a great pleasure to hear from Max. It's just unbelievably good at this.
Thank you so much. Thank you for the invitation. Yes, it is a great pleasure.
Pessoal, alguém tem alguma pergunta, algum ponto específico, alguma dúvida? A oportunidade agora. A gente tem mais uns minutinhos com o Max e fiquem à vontade para perguntar.
We had a comment from Dr. McAlpine in the messages. Is that it? So thank you, Professor McAlpine, if you're here with us in this lecture. Anatomy, you're definitely a master in anatomy also. So it's an honor for us.
Yeah, thank you so much.
Okay. Again, thank you, Cristiano and Dr. Didenko. This lecture was recorded, so if anyone want to recap anything, and we have to schedule the second session, Dr. Didenko. I think everybody gonna want it.
Great. Is it possible for me also to have these recordings? Because maybe I will...
Sure.
Yeah, for sure. Yeah, I will share you the file. Usually I upload on YouTube, and is not listed YouTube's file, but I'll send you the file, the
Perfect.
the
Thank you.
video
Thank you.
file. I'll share with you for sure, Max. Actually, it's your file, it's your presentation. Maybe you just record it.
Yeah. Thank you. Thank you so much.
Thanks. Bye bye.
Bye.
Ok, então, pessoal, eu vou mandar o link depois. Vamos organizar, né, uma segunda sessão. At least a second session we'll have, Max, with you, now talking about the HA, flutter, and ventricles. I
Yeah,
think
yeah.
I think it works better to because like 1 hour and a half do not work, and it's great. Thank you so much. It was great, but session. As I told you before, I want to bring you to Brazil, and let's see if we can manage this, and that's great. Thank you so much,
It's a
and
great pleasure. Thank you. Thank you.
obrigado
Tchau.
a todo mundo que está aqui.
Obrigado.
Bom dia, good afternoon, Max.
Yeah.
And Francisco.
Yeah.
Ciao.
Have a nice day.
Goodbye.
Thank you, Cristiano, for inviting us.
Hey,
Great pleasure.
good to see you.
Bye-bye. Good to see you.
Bye.